Okay, now it's official. um, so okay, this is hopefully our last strictly virtual residency. And we've been saying this all week. All the things that we used to do in person, we're now doing virtually. And Thursday has been our traditional Capitol Hill Day out on the town. In DC in the summer, which place I happen to not be at the moment, we know how wretchedly hot and humid it is. And Thursday it was always a coin flip. Is it going to be tolerable or absolutely completely painful to schlep around all on Capitol Hill and do all that stuff? We would normally go up to the Humphreys building and meet with HHS, who we'll be meeting with later today virtually. And then we'll go usually to a couple of a senator's office and a congressperson's office. Senator Baldwin, who will be meeting with her chief legal advisor later today, and usually a congressperson or one of their staffers to talk about what's going on the Hill. And usually we ended the day by going to the Whitman Walker Clinic there on 14th Street. When we first started doing this, Whitman Walker, the office we went to was the Elizabeth Taylor Center. And prior to building two beautiful new spaces that they have to work with, both on 14th Street as well, where the Elizabeth Taylor building is, everything was crammed into this very small space at 14th and S, I guess it is, or yeah, 14th and S. The Whitman Walker goes way back, and Dan and Megan are going to share a little bit about that today. But we ended the day on Thursdays, just sweating, exhausted, dumping ourselves into the building, using their air conditioning, and getting sometimes a tour, but usually just an overview of what Whitman Walker is, what they do. They've changed over time, and Dan and Megan here are going to talk a lot about that. And more specifically about the services they provide, the activities they're in, some of the advocacy work and all that. So we get to do this from the comfort of our respective homes online. And I want to welcome Dan and Megan for taking the time, and thank them for taking the time to talk with us today about Whitman Walker. So it's all yours.
Hi, all. Thanks so much for having us. Dan and I are just going to kind of blather at you, and we can chat. We thought it could be dynamic, so please feel free to interrupt us, ask questions. We're not going to think you're rude. Sometimes even the management of the chat makes it a little bit more wonky. So really and truly feel free. If you want to raise your hand, that's fine. But also if you just want to unmute and say, wait a second, Dan, or wait a second, Megan, we're totally fine with that. I also wanted to let you all know that I went to GW. I got my master's there a long time ago. So it's wonderful to do this virtually. I haven't been on campus in, I think, 2 years. I've barely been anywhere west of 14th Street in 2 years. But hopefully we'll be able to get over to you all soon. I am our Chief Program Officer. I've been here for a little over 13 years. I actually started as our transgender care coordinator. I came here right after my work in the Peace Corps. So I did something called a Master's International, where I got my undergrad at UVA in biology, went to GW, did all the coursework for a master's in public health, and then went to Honduras, where I worked in HIV and gender in a small town at the end of the paved road. And then I got 3 credits there for my practicum, and then came back and finished my coursework and interviewed via Skype for Whitman Walker. People still used Skype then. And was excited enough to get the job. And, now my role has changed, obviously, significantly. So as our Chief Program Officer, I oversee basically all of the non-clinical services. So our wraparound services and our support services, anything from IT and facilities to our front desk, our call center, our public benefits and insurance navigators, our community health and outreach, our legal services team, our youth services team, and our care navigator, like non-medical case management work. So it's a broad, wide variety of services, and it's wild to work here. And we'll talk a little bit about, Dan is about to introduce himself and talk through the policy. I'll also give you all a quick overview of Whitman Walker and also talk a little bit about our response to the COVID pandemic. I know some of you are very entrenched in that work. And so hopefully that's helpful, but also feel free to share your experiences with us as well. Dan, before I totally start blathering, do you want to introduce yourself?
Sure. Yeah. Hi. Glad to be here. Dan Bruner. My pronouns are he, him. I am the Senior Director of Policy at Whitman Walker. My training is as a lawyer, and I also have a master's in public policy. I've been involved in certainly HIV related work, and I was started volunteering with Whitman Walker in the really horrible early days of the epidemic in the 1980s. In 1995, I left my law firm and joined the legal staff at Whitman Walker. I was director of our in-house legal services for 10 years. And then when in 2015 we created a new policy department, I moved over to do policy work full time. I apologize if there's noise in the background. I've got contractors in the house, so I hope it's not too distracting. So I'll talk a little bit about the history of our policy work, current issues that we're involved in, and what I see as like the hottest issues for LGBT kind of health and wellness policy a little later. But I'll turn it back over to Megan to talk about kind of Whitman Walker and our patient services.
Thanks, Dan. Are you all familiar with Whitman Walker? Either not, yes. Okay. So I'll go into kind of a brief overview, but please feel free to stop me if you want me to either move past stuff because you already know all of this, or you'd like me to kind of delve into a few more things. I'm happy to do either. So we're a first responder to the HIV epidemic in DC. We've been around for more than 40 years. We are a 501c3. We are considered a center of excellence for HIV and LGBTQ care. We were officially chartered in 1978. In the early 80s, we took the lead in providing services to people living with HIV, as well as offering support to family and friends who were serving as caregivers. So before there were really even treatment or tests, we were really here to help folks. Often we use the words die with dignity, which is a challenging sentence, but it's the most accurate way to say it because it was the most, the best amount of work that we could do, the best use of our time, and really the most beautiful work in some ways that we've done in our history. Over time, our goals have broadened beyond the HIV services. We've matured into a full service community health center about 10 years ago. It's still existing today and thriving. While we were chartered as Whitman Walker Clinic, we are now called Whitman Walker Health. Our mission is basically to offer affirming community-based health and wellness services to all with a special expertise in LGBTQ and HIV care. It's always a challenge for Whitman Walker to kind of talk about what we do, because often the answer is, yes, we do that. So it's like, but you only serve HIV positive folks. Nope, we also serve HIV negative, but you only serve LGBTQ folks. Nope, we serve anybody. We're really big on, we want folks to check whatever boxes they want, but we also don't require anyone to check any boxes. And, as gender is fluid, sexual orientation can be fluid. Even in some ways, while HIV, obviously you're always HIV positive, going from, we don't use the word AIDS anymore because that's fluid as well. You might have less than 200 CD4 cells 1 month, and 1 year later, you're thriving, right? So a lot of our services are fluid, and we work to support patients in whatever that view is. So we are very proud to say that we are now a federally qualified health center. We are also an HRC Healthcare Equality Index leader, and we have been, high, if not 100% on that since 2011. Since 2017, we are also a primary care medical home level 3 facility for both of our clinical sites, which, as Stephen mentioned, we've got 2 clinical sites, one on 14th Street, and then we've got another clinical site in Anacostia. Our third building, which is actually one that I'm sitting in right now, is what used to be the Elizabeth Taylor site, which Stephen mentioned earlier, that is at 14th and R. That is now part of a joint venture. So we were actually lucky enough to own the entire city block, which, some people might have said, who wants to own a city block on 14th Street? Well, a lot of people do. Just didn't know that maybe in 1985, right? And so we were actually able to redevelop this site. So we have the majority of our administrative offices on here, but we also have our research arm, our policy arm when they're on site, our community health team, some of our wellness services, billing services, legal services, insurance verification on here, but we don't provide medical care, dental care, or behavioral health care on this site. Those are at our other 2 clinical sites. And then above us are residential, so apartments as well. And then below us, we have something called the Corner, which is our cultural site, as well as an Amazon store has moved in, a Bluestone Lane has moved in, a Parachute has moved in. So it's very different for a nonprofit to do things like this. And we get a lot of questions around, how do you do that? How do you pay for it? You all must be so rich. We're not. So I'm just going to start off this conversation with that. We do believe that we want to make sure that folks know that they are worthy. And so we build our buildings in a way that shows, it shouldn't be that I go to this place that doesn't look nice because I'm a Medicaid patient. It really should be, I go to this place and it looks nice and I'm a Medicaid patient, right? And so it's very important to us that this looks like a beautiful building to all. But we, just like anybody, probably just like you all, we have loans, we have mortgages, we take grants and all those things, but we are not swimming in cash. And our biggest goal is to continue to be sustainable and be able to do this work. But it's always a struggle. And I'll get in a little bit to how big of a struggle it was in the 2020 and continues to be in the 2021 years, specifically around COVID. So we are an integrated model. We've got a variety of multidisciplinary wraparound services, like I've mentioned. We serve care to over 20,000 individuals. Around 16,000 of them are medical care specifically. And then, like I mentioned, we do a significant amount of HIV and STI services, but they don't necessarily get their full medical care here. We do a ton of chronic disease management as well as general wellness for those who face these critical health disparities that we are always working to address. So some of the wraparound services that we provide are medical nutrition therapy, acupuncture, Reiki, massage, and yoga, medical case management and care navigation, treatment adherence, and then I've mentioned dental. We do mental health or behavioral health, substance misuse care. We have psychiatry, individual, couples, and group therapy, a wide variety of community health programs that we worked to pivot from more of a sexual health and chronic disease management to a COVID response team. Legal services, public benefits and insurance navigation. We're very proud of our public benefits and insurance navigation work. We actually started some of the public health insurance navigation work in the district before there were things called health assisters, if you've heard of that, under ACA, where people get trained up to assist, it's quite a term, I know, but to assist folks to get their health insurance and kind of get on the marketplace. Erin Lubier, who's an attorney by trade, has worked with Dan for years, really helped this model work locally as well as nationwide. And we are the oldest medical legal partnership in the United States of America. And one of the really unique elements of that is the attorneys are embedded in the clinic. So in other places, often healthcare providers have a very formal relationship with attorneys. We actually have attorneys on staff, and they're part of the multidisciplinary team. And then, a really big thing that we do, as you can imagine, is we proactively work to minimize health disparities in our diverse client base. So our like I mentioned before, our patients are very diverse. About 30% identify as African American, about 20% identify as Hispanic or Latinx. About half self-report as gay, lesbian, or bisexual, and over 13% of our patients report having a transgender identity, a gender expansive identity. And 61% of our clients fall under 200% of the federal poverty level. So as you can imagine, that's a wide variety of patients that have a wide variety of needs. So something else that's really important to us is cultural humility, making sure that we are able to support the patients, that we come at it from a wide variety of cultures ourselves, that we mirror our client demographics. So our staff is incredibly diverse from a racial and ethnic affiliation, sexual orientation, gender identity, HIV status, as well as linguistic background. It's very important to us that when possible, we speak the language of the patient with us. So about 20% of our staff speak Spanish fluently, bilingual English, Spanish. Before I keep going, or don't, are there any questions or anything that you want me to clarify on just like Whitman Walker's kind of clinic side?
I was wondering, are you, you mentioned being a federally health qualified center, or federally qualified health center, sorry.
No worries.
Are you also one of the designated HRSA sites?
We are a HRSA FQHC.
Okay.
Yep, we have been for about 6 years now. And what really, so it was actually challenging for us to be designated an FQHC. We were very much seen as an AIDS service organization. And it's really interesting now that we are an FQHC, HIV, especially with the end of the epidemic, emphasizing and the grants and funding coming behind that, FQHCs are kind of now getting on the ball and working towards HIV, but previously it was kind of you were an FQHC or you did HIV work. There wasn't a ton of both. I'm sure you all are familiar with some of the other LGBTQ organizations like Fenway Health, Chase Brexton. We're in a similar boat as them, working to be both an FQHC as well as providing HIV care and focusing on the LGBTQ community. But it's a small handful of us working towards that. Great question.
So
go ahead.
The services you provide, it's at your medical home. Do you also provide full service OBGYN?
So we currently do not provide full service OBGYN. We have had a medical midwife on staff before, as well as a GYN on staff. We currently provide the GYN. We don't provide the OB. Okay. So what we do is we have a formal relationship with 2 FQHCs in the District of Columbia, Mary Center and Community of Hope. We also work very closely with Washington Hospital Center MedStar, depending on the needs of the parent who might be pregnant. And so what we do in that case is we will provide care for the person who's pregnant, their HIV care, anything else that they may need, but the actual care of baby, we do contract that work out. I don't know if you all have, I can get into it, but we're looking at expanding our footprint in Ward 8. So we have a very small clinic in Ward 8 right now with 3 exam rooms.
Wow.
We're looking to, yes, it's been there for about 25 years, been there for a while. It's right by the Anacostia metro station. People actually love it because some people just really like small. You walk in and it's like cheers, everybody knows your name. It's, very relationship, but it's small and it does not mirror, frankly, the state of the artness that our other clinic does, right? And we want, again, when we're talking about worthy, there's no reason we should have anything that even looks like better care in Northwest and not have that in Southeast. That's inexcusable. So we are working at expanding our site there. St. Elizabeth's has broken ground. We're going to have a 100,000 square foot building there. It's about double the size of our clinic on 14th Street. It's gigantic. It's not all clinic space, so I'll get into the other arm of Whitman Walker. But there we are hoping to expand into more supportive care for parents, trying to kind of decide what that is, while also acknowledging, especially Community of Hope and Mary Center, they do this work so well. And so, you know, to your question, Jared, as an FQHC, we don't want to compete or steal clients either. We want to make sure that we're filling a niche that isn't there. And if the OB work is being done well by FQHCs, we want to support in other ways. So are there ways that we can support from an LGBTQ angle, right? A gender affirming angle or an HIV angle. So that's how we support one another, or at least aim to. It's not always perfect, as you can imagine.
Oh, sorry.
No, go. No, it's great. It's more fun this way.
I did have one other question.
Yeah.
Clinical psych is my other area in addition to being a student at GW. And I was wondering, are psychological assessment services something that's offered to? Oh, okay, great. Yeah, because I know that can be really hard to access for marginalized communities and lower income communities.
So one of our largest challenges is we are one of the few Medicaid providers for psychiatry as well as psychotherapy in the District of Columbia, which is great because we are able to fill those shoes, Jared, but we are not able to fill them as large as we would like. So we continuously have a long wait list, and that can be very frustrating. So that's another thing that we are looking at, is trying to beef up our staffing there. I can share with you all, during the pandemic, we've had a lot of turnover, especially in our behavioral health team. We're actually seeing it everywhere. I think folks are tired. I think also, some folks moved home during the pandemic because they didn't have to be on site, or they and now they want to only do telehealth, and we are requiring a hybrid model. And some folks like, well, I can do, X in a different place and I want to do that work. So we do right now have, I want to say 2 or 3 openings in our behavioral health team. We did just give an offer to it's either a psychiatrist or a psychiatric nurse practitioner. I don't remember which, but we were able to give an offer there, and we'll be bringing them on board. But that will put us at 3 FTEs, and frankly, we could probably use triple that. But they're not easy to come by. And newsflash, this may shock you all, we don't pay as well as folks would like us to pay, right? Like, you can go to the bigger places, you can go to the larger health systems, you can go to Kaiser, you can go, probably, ask Dan, he could have probably gone to any law firm and made 3 to 5 times what he made here. So there are absolutely some give and takes. And so not everybody is able to not make as much money and come here. One of the things that we do to try and support, good candidates to come here, is we provide training, which is obviously helpful to get clinical hours, whatever you have to do. But also, because we are an FQHC, we are able to get loan reimbursement and forgiveness from the federal government. So sometimes folks are, that means a lot to them, depending on if they've got hundreds of thousands of dollars of loans.
So by training, by training, does that mean you have like maybe PA students, nurse practitioner students coming in to do clinical hours?
Exactly.
Are all of those students primarily from Maryland, DC area?
They are primarily from the Maryland, DC area. We partner with GW, we partner with Georgetown, Maryland, University of Maryland, and I'm missing one that I cannot think of, but there's at least one more, but they are usually local. They don't have to be, but usually that's the goal, because then they're also working towards like a DC licensure. But I feel like you're thinking about something.
I teach in Rochester, New York, in the family nurse practitioner program and the undergrad program. And I have a number of students who really wants to do clinical hours in an LGBTQ health center.
Interesting.
We're trying to get a partnership with Calvin Lord downstate.
Sure.
But I mean, it would be great. I know there's a whole licensure issues.
There's lots of things, but it doesn't mean we can't talk, right? Let's think through it. Stephen has my email, absolutely feel free to connect us, and I can connect you with our clinical lead who does education, and we can see what I don't know, like, it's definitely not my expertise, but we could see what we could do for sure.
All right.
We're not that.
Emails. I'll send that around now so you're connected.
Thanks.
Super.
So I have sort of a loaded question. Sorry.
Oh, I'm excited.
I'm an adolescent medicine physician in DC, actually. And so I was wondering to what extent Whitman Walker reaches into the pediatric realm to provide
Yeah, great
care?
question. So that is fairly recent. In 2015, so until 2015, we were providing care, mostly medical care for 18 and over, and HIV and sexual health care for 16 and over. And then in 2015, we did something that we call a formal collaboration with Metro Teen AIDS. Metro Teen AIDS was a smaller organization in the District of Columbia, really focusing on HIV and sexual health and pregnancy, like prevention and education in folks 13 to 24. And so they unwound, and that's why we call it a formal collaboration. We didn't actually merge with them. They unwound, they laid off their staff, they transferred their grants to us. We hired their staff. We kept their programming, transferred their patients, and kept their staff. And so we've been doing that work since 2015. And then starting kind of mid 2016, we started providing services to young people 13 and over. So we don't currently provide care for under 13s. We, again, similar to the OBGYN conversation that we had earlier, we contract for pediatric provider under 13. But again, with our expansion to St. Elizabeth's, that's also something we're looking at, really with a focus, especially on gender affirming services. So we do a lot of work for young folks with gender affirming services in our legal and in our insurance navigation arena. We don't have an age requirement there. We've done gender and name change paperwork for folks as young as 5. You know, we are doing those wraparound services. And even when I just said that to you all, I got like a tingle up my spine. Like, that is work that we are so proud of and we want to be able to maintain. And for those of you who are familiar, there's a very long wait list at Children's to be able to support gender affirming services for young folks. So we really want to get there. There's, you know, Dan knows I'm very candid, so I think it's important to talk to you all very candidly. Things like puberty blockers are a challenge, right? Talking through some providers, it makes some providers nervous. What does this do to bone density? You know, if you're doing a puberty blocker with a 7-year-old, 8-year-old, that's quite young, right? I do think we're getting there. We're conversations with this nationwide. We're part of what's called the National Trans Line, where our providers actually help answer the phone for other providers to call and kind of do like multidisciplinary conversations. But we're still working on what our ability is to be able to provide that care. Our goal is absolutely to be able to expand to younger than 13. Will we go to babies, Joe? I don't know. You know, I like babies, people like babies. But, you know, as I said earlier, we do a lot. And we're also careful about, we want to do what we do well. And there are other good pediatric providers out there. So we don't, again, want to like jump into places just because we should, you know, because we feel like we should just do the full gamut, which is why we would really probably focus on the gender affirming side of pediatric care. Does that answer your question?
Yes, I was curious because in full disclosure, I'm an adolescent medicine doc at Children's. So it is, Whitman Walker's has always sort of been in my
So then
corner.
you're very familiar with, you know, everyone is banging down your door, right? And we do partner with folks at Children's on transition for HIV care. So often, you know, because it's what makes you an adult. It's not 18, like we all know that. And we also know that we lose our young people, especially who are HIV positive, in that like 18 to 24 to 26 transition. I know when I was 24, I sure didn't feel like an adult still. And so we have been partnering with Children's to you know, improve that transition from really from pediatric to adolescent to adult care.
Thank you.
Sure, thank you for the question. So I want to make sure Dan gets to talk because he's way smarter than me. And so the main kind of kickoff that I wanted to give you all for Dan is a couple of years ago, Whitman Walker, in order to diversify, went from, so I mentioned how we were Whitman Walker Clinic, then Whitman Walker Health. We are now Whitman Walker Health System. And so Whitman Walker Health System and Whitman Walker Clinic, doing business as Whitman Walker Health, are sister companies. So the former CEO of Whitman Walker Clinic, so the FQHC, is now the CEO of Whitman Walker Health System. And then the former deputy executive director of the clinic is now the CEO of the clinic. The main reason, well, there's a variety of reasons, but one of the main reasons that it's siblings rather than a parent company is due to FQHC rules. The FQHC board cannot report to anyone, right? They need to be the end all be all to clinic work that then goes to HRSA. So under this system, we've transitioned over policy, which is Dan, education, foundation, research, and then we've got something called a joint venture, which is what I mentioned earlier, where we have some real estate holdings. So there were a wide variety of reasons to do this, one of which is to protect the clinic, right? We want to make sure we are able to focus on the clinic and the patients. Vice versa is to protect these other services. When you're an FQHC, you're always going to focus on the patients and the clinic, right? Patient first. But then that might mean that things like policy or research could be put on the back burner because they're kind of the long haul, and you're always going to deal with a fire right in front of you. So we are so incredible at this policy work and research work, nationwide, internationally wide known for this work. We wanted to make sure that it got the time, energy, funding that it required. We also wanted to be able to broaden our fundraising efforts. As an FQHC, well, most folks, when you think of a board, you think of like a give or get. You have to give $100,000 or $10,000 or whatever the dollar amount is. As an FQHC board, we are required to have 51% consumer. So 51% of our board need to be patients. And we need to ensure that we really get the patient feedback from the folks that need us the most. Often those are also not folks that are able to write a large check. And we would never want to compromise that work. So in order to be able to beef up our fundraising efforts, we started something called the Whitman Walker Foundation that can now have their own board and be able to support fundraising and not necessarily have to be a clinic patient. Although for all of you who are local, and my family says I'm allowed to say this, I've made them sign off, so I'm not breaching any HIPAA. My family, my friends, they come here. So I don't want you all to think that, you have to be under 200% of poverty or anything like that. It's a wonderful local community health center. So feel free to come and get your care here should you want. But yeah, so now we've got this institute, and an arm of that is policy, and that is Dan's shop. And I now turn it over to Dan to be able to share more about his work with you all.
Yeah, so just a little, very little history. The policy, Whitman Walker's involvement in policy work really started during the HIV era, the early years of the epidemic when, as Megan pointed out, we actually hired our first in-house legal services director in 1986 and expanded from there. So particularly in the early days of the HIV epidemic, when there was widespread ignorance, misunderstanding, fear, and kind of discrimination kind of everywhere, we did a lot and still do a lot of legal work for individual clients, but also a lot of policy advocacy. We've been involved in law reform efforts both locally and regionally and then nationally on addressing discrimination in healthcare, employment discrimination, advanced planning documents, particularly for, gay, lesbian, trans people and other people who, without traditional like legal recognition or acknowledgement of their relationships, confidentiality issues, end of life issues, etc. When we were doing that, really focused on HIV, not surprisingly, it always had a sexual orientation discrimination component to it, just given the demographics of the HIV epidemic. But I would say maybe starting 15 years ago or so, 10 to 15 years ago, in the legal department, we started expanding beyond kind of HIV work to LGBTQ work, particularly around transgender issues, access to health care and discrimination, and also assisting people with name changes and gender marker changes in legal documents, identity documents. We do a lot of that work. And in 2015, we created a new policy department specifically so that we could devote more resources to longer term policy issues, because kind of similar to what Megan was referring to in our legal services department, of course, the focus has to be on what the individual clients need, what their individual cases are. So it sort of was a challenge to really focus on or have sufficient resources to look at the policy issues. So, but we did some, even in legal services, we were involved in some major victories on the policy and the law reform front. We worked on and were responsible for an amicus brief in the Supreme Court's Bragdon case. I don't know if you're aware of that. It was the case in which the Supreme Court held that HIV infection, even if it was asymptomatic, was fully protected by the Americans with Disabilities Act. And we were very involved along with Lambda Legal and others, in fighting a widespread health insurance practice, which was to impose very low lifetime caps on coverage of HIV. So, for instance, somebody's health insurance policy might say your lifetime cap for coverage for all issues is $1 million or $2 million. For HIV, your lifetime cap is $15,000. So we were involved in some of the litigation around that. And the interesting thing, this happens in policy work, law reform, for some legal reasons I won't get into unless you're interested. We've actually lost those cases legally. But what happened was, in the course of the litigation, what really came to light is the insurance companies had no actuarial basis whatsoever for singling out HIV, that it was purely a matter of bias or insurance companies wanting to make money by focusing on a community that was particularly vulnerable. And so once the evidence came out that there was no actuarial or evidentiary basis for the practice, the insurance industry dropped it. It's like, okay, never mind, we won't have these caps anymore. So that was sort of an interesting development. What we're doing right now on the policy front is a number of things. We are actually kind of spearheaded and helped create a roundtable that's focusing on federal health policies related to LGBTQ and intersex people. And we've actually had, we just started that at the end of last year. Now that we have a much friendlier administration than we did for the last few years, We've had meetings with the White House Domestic Policy Council and with Dr. Rachel Levine, who's the Assistant Secretary for Health. So we're very much involved in that work. We have been for several years at this point working with experts from around the country, including some folks at GW, to develop recommended guidelines for training healthcare providers on cultural competency or cultural humility around sexual orientation, gender identity, and intersex patients. We've actually done a lot of work locally on criminal law reform around consensual sex work, which is something that creates a lot of barriers for HIV treatment and prevention, particularly for transgender women of color who are, enormously impacted by HIV. And, the criminal laws just create all sorts of scenarios in which they're just continually harassed, by the police and the criminal justice system. And we've actually been involved during the Trump years. We filed a lawsuit working with Lambda challenging the Trump administration's rule under the 1557 of the Affordable Care Act that tried to roll back the Obama era protections against healthcare discrimination based on gender identity and sexual orientation, and also protections for patients with limited English proficiency as well. That litigation is still ongoing, although it's on hold right now for the Biden administration to figure out what their next step is. I think they're actually going to issue a new proposed rule under Section 1557, but there are a lot of issues there. So the impression we get is that proposed rule may not come out until next spring. And then also, when the Trump administration issued a so-called conscience protection rule in healthcare that you may have heard of, that was pretty shocking, that basically said anyone who works in healthcare in any capacity has the legal right to opt out of being involved in any procedure or type of care that they personally disagree with on religious or conscience grounds. So we were one of the parties that filed a lawsuit against that, and we've actually that rule has been vacated as unlawful and unconstitutional by 3 different federal district courts in different parts of the country. The Trump administration filed appeals, which are in now the courts of appeals in the Ninth Circuit out west and the Second Circuit in New York. But that litigation again is on hold until the courts hear from the Biden administration, like what the next step is for them. But in the meantime, thankfully, that rule is vacated. It's not in effect at all. So, and as I talk, if you have questions or comments, just interrupt me at any time or use the raise hand function on chat, whatever works best for you. In terms of kind of what the biggest kind of issues are right now on the legal and policy front, this is all stuff that I'm sure you're very aware of. One is just this avalanche of attacks at the state level on trans people and trans kids, especially trying to make providing gender affirming care to minors a crime or a basis for a state's abuse and neglect agency to, come in and maybe even take a kid away from the parents if the parents are supportive of the care. And this big brouhaha about trans kids being involved in sports at the junior high school level, especially, trans girls having a quote unquote unfair advantage in competing in girls sports teams with cisgender girls. Which, from what I understand, medically is nonsense and legally nonsense, but that's certainly a big issue. What is going, basically, how to apply the Supreme Court's ruling in Bostock, the Bostock case, which was under Title VII which deals with employment discrimination, where the Supreme Court, kind of to everyone's delight and to the surprise of some of us, ruled that sex discrimination under federal law is necessarily inclusive of discrimination based on gender identity or sexual orientation. So applying that to healthcare, to housing, to education, et cetera, is, I think, a big priority of the Biden administration and certainly a priority of the advocacy groups. Passage of the Equality Act obviously is, a goal of all of us, expanding access to gender affirming care, both sort of defending against these attacks at the state level, but also addressing insurance companies, and actually surprisingly Medicare is pretty bad about covering gender affirming care, much worse, for instance, than a lot of private insurance is, or a lot of state Medicaid plans. And the type of health plans that people get as federal employees, part of the federal employee health benefit system, those plans are pretty lousy as well for a lot of gender affirming care. So a lot of advocates, including our folks, are starting to work with federal agencies on those issues. And then one thing I wanted to flag in particular, because I think it's really important in healthcare and also just very kind of interesting as a matter of law and policy, is what do you do about religious-based refusals to provide healthcare to people, and how do you balance laws at the state level and the federal level that prohibit discrimination, say based on gender identity or sexual orientation? How do you balance that on the one hand with religious beliefs? On the other hand, whether it's for instance, a Catholic hospital or a Catholic foster care or adoption agency, where you have, a religious institution with this that provides this kind of service that has, at least arguably, like a theology or a set of beliefs that conflict with providing certain types of care. So that's one issue. Another issue is, leave aside the institutional issue, what do you do about the individual practitioner? the nurse, the doctor, the PA, or frankly, someone at the front desk who says, based on my religious beliefs, I don't want to take care of this person. And that, that issue is starting to come up a lot. It's percolating in through a lot of different pathways to the Supreme Court, really under two different sort of legal theories. One is the First Amendment, freedom of religion or freedom of speech. And the other is a federal law called RFRA, the Religious Freedom Restoration Act, which initially was passed by Congress with bipartisan overwhelming support to, for instance, protect individuals whose religious practices were getting them, say, fired from a job. For instance, a Native American in, I think it was Oregon, who was fired from a job and couldn't get unemployment compensation because part of his religious practice involved ingesting psilocybin mushrooms as part of a religious ceremony. Although that was the initial intent of the Religious Freedom Restoration Act, it's now being used, for instance, by famous case Hobby Lobby that said, we have an employee health plan and we don't want to include contraception or coverage of certain contraceptive services because we personally believe that type of contraception is too close to abortion. And that violates, this is Hobby Lobby, a secular corporation, so it's not the Catholic Church, for instance, saying this, but it's Hobby Lobby saying, we're the owners of the company and this is our personal beliefs. So I think those cases are coming up to the Supreme Court. We've seen a couple already, the Fulton case, which you're probably aware of, decided a couple of months ago, which involved a Catholic foster care agency fighting with Philadelphia, saying, we don't want to have to comply with Philadelphia's non-discrimination ordinance, which was, in our city contract. And the Supreme Court kind of found, in my view, a creative way to sort of duck the real issue in that case. But these issues are, going to come up just like they've come up, for instance, for someone who is fined under a state civil rights law, who's, say, a baker, for refusing to provide a wedding cake for a same-sex couple, or a florist who turns away a same-sex couple for, wedding flowers, even though that's what their business is. So there are a lot of really important and interesting issues there. And of course, what really concerns us is, although certainly I believe that it's a dignitary insult and should be illegal if a baker tells me I'm not going to do a wedding cake for you or an anniversary cake for you and your husband. To my mind, healthcare is a much more concerning area than wedding cakes or flowers. And how do you balance or legally assess someone's, let's say, sincerely held religious beliefs, which include a concern about that they don't want to be involved in enabling or participating in an activity that they believe is sinful. But my exercise of my personal religious beliefs imposes serious or has serious adverse consequences for you if you need health care. And, for instance, how would GW Hospital be able to function if everyone who worked at GW Hospital, all the way from the brain surgeons to the folks at the front desk, had the right to opt out of any procedure that they personally disagreed with? That just seems to me to be untenable, even just as a practical matter. And then if you say, okay, but how about, for instance, a Catholic hospital or religiously affiliated hospital? There are large parts of the country where, the local Catholic hospital, especially in some rural areas, is the only game in town. That's really the option. It's not like DC or New York City or somewhere where you might say, this procedure, you can't get this service at hospital A, but you can get it at hospitals B, C, and D. And it also has a lot of implications for, I think, nursing homes and long-term care and elder care, because it's really surprising. I really came across a lot of this when I was dealing with my own aging father and his wife. Lots and lots of long-term care facilities. If you look even at their website, you see that you don't have to go many clicks to find a long description of their religious mission and the fact that, the reason they do this work is they're called to it by, God or Jesus or whoever. And those institutions probably have, let's say, sincere religious objections to, for instance, how are they going to treat an 85-year-old transgender woman, or an 85-year-old lesbian couple who need long-term care. So I think these are really important issues. There's the legal discrimination aspect to this, and to what extent religious beliefs give you an exemption from non-discrimination laws. And then just to circle back to what we were saying earlier, even if treatment that may not rise to the level of discrimination can still be ignorant, unwelcoming, unaccepting. So there's a huge need for cultural competency, cultural humility, training of folks, which is why programs like yours and folks like you are, who are actually in the healthcare world, are so important. So I've been rambling for a while, and I think we're already past the hour, so I apologize, but if there are any questions.
Hi, I am the head of case management at an LGBTQ medical clinic in Connecticut. And I actually deal a lot with legal issues, even though I have absolutely no background in this. And a lot of the time, it's all for workplace discrimination cases. And so we've been filing them through our state CHRO process. And, when I talk to the office, they say we do not have enough cases for precedent to even be set for the workplace discrimination. So it's really hard to even get people to submit them because of the immediate response from CHRO saying it's probably not going to happen. So, I mean, what is a way that I think it would be better for organizations like ours or small time case management people that are trying to get into workplace discrimination cases? Because like some of them that I have are against, like Taco Bell is one of them, you know, and it's not like just a small company. So any help?
Yeah, well, particularly after the Supreme Court's Bragdon case, I think a lot of employers just need to be educated. It's like, guess what, folks? You're now violating federal law by doing this. There may be, state laws in Connecticut, or even some municipalities may have ordinances, but a lot of times employers and the lawyers who advise them take Title VII or, federal law more seriously. I would certainly say, and, I can send you the contact information. I would say both Lambda Legal and, the ACLU. A lot of times they won't necessarily take a case themselves if it's not like an impact case of some sort, but a lot of times they can rattle the cage, if you will, of an employer and get a good result quickly. And they also have pretty extensive networks of, local, attorneys and local organizations that, legal organizations that actually do these cases. So I would certainly encourage that. But yeah, I'm happy to send you the, information, or even make the, like an e-introduction for you.
Yeah, thank you. It's just been so, hard when we actually had one case actually go through, and it has been dragging on, but basically it only came out to be $1,000 payout when the case itself was actually more devastating than that. So, and, she wanted to end the case after having gone through this for like 7 months, because by that time it was just so exhausting. So, I mean, I had some GLAD help, but they were getting an attorney that they were going to charge, I think, $450 per hour just as a consultation to start, which I thought was bizarre because I thought that's like a pro bono type of way. So, like, I was going to cover the legal fees for the patient, but it was just bizarre to have some of the help I thought was supposed to be for the community, and it's like, here, but let's pay a lot more money for you to see an attorney.
Yeah, I mean, I don't know the specifics of, that situation, but I'd almost be inclined to point out to GLAD that, hey, this lawyer that you referred us to, this is what they were telling us, because that doesn't, I mean, a lot of times a law firm that will take a case, even on a contingency basis, will say, I'm sorry, but you, the plaintiff, need the client. You need to cover like our filing fees or that sort of thing, which is much more modest, but they're not, it doesn't sound right to charge a fee like that for an initial consultation. And I know that in a lot of these cases, when I did this kind of litigation myself, that the payout or the damages for the client might be a small dollar amount, but if under these fee shifting statutes, the employer can be held liable for the legal fees, and that can be, even in negotiations, the real hammer for people because, my client might have had a case that was only worth, quote unquote, $15,000. But by the time we got to that point, I had run up, $75,000 in attorney's fees that they might be on the hook for. And, the point isn't, for attorneys to cash in, but the point is if that's the way that you get bad actors to pay attention to you, then, those fee shifting rules can be very helpful.
If there, well, I actually wanted to talk about a little bit. You mentioned about like how Whitman Walker expanded, and this is a total shift of gears. And is there any? Excuse me, I should actually, before I do that, ask if there are any other questions, sort of like in the policy arena, and that's while Dan's on here telling us about that. Well, one of the interesting. Oh, Caroline.
I have one more. I'm sorry. Just because I do a lot with the ID documents. Do you all have a clinic that you end up doing for like a day where all of your patients can come and do documentation switches and gender marker changes with providers, or is it just through case managers that you're doing that with?
No, we have clinics that happen once a month, and we have largely volunteer lawyers, but they're specifically trained to do that work. I mean, some of it now, of course, is at the federal level, like your Social Security documents, your passport, etc. But of course, a lot of it, your driver's license, your birth certificate, are at the state level. But I know that there are other, legal service providers that do that work. Our work is really focused, of course, on, for the most part, Maryland, DC, and Virginia. But I know there are providers in New York that do that work, and that probably, would be knowledgeable about Connecticut law as well. So again, I'm happy to send you.
Yeah, for us,
info.
our state's amazing for it. So I know how to do all of that, but I've been wanting to start a clinic to have patients come there. So it's nice that you all have that. So I'll look into that more.
Yeah.
And they do have a staff of paid attorneys that are just, really terrific. And like Megan was saying at the beginning, a lot of them, Dan's one of them too. They're turned down opportunities for far better paying jobs. But I have a friend. You guys probably know Murray Shield pretty well, but
Oh yeah.
He was so delighted. He was in, like so many lawyers I know. They get to working and they're making all this money and they realize, this is really not important. And the staff of attorneys there and everybody, I mean, care providers as well, are, they're there because they're really dedicated to making this stuff happen. And Murray could not have been happier than when he made the switch to Whitman Walker and, started doing what he thought was really important work.
Oh yeah. Yeah, we had known Murray for years, and I actually hired Murray.
Yeah.
So yeah, Murray's fabulous.
Yeah, good hire, and he's about as delighted as he can be. So, I just wanted to touch base on when you were talking about, and Josh used to talk about this when he would do these briefings for us. How you just the interesting part of DC, like you mentioned, owning property on 14th Street. 30 years ago would be like, oh, great. We have pawn shops and peep shows and stuff like that. And now, of course, anyone who's been in DC for any period of time knows just the vast change of quite frankly, gentrification of the neighborhood.
Yeah.
But one of the ways, and Don explained this to me, and Josh did as well. But the way, one of the ways, like they were both saying, Whitman Walker is not flush with cash. But over the course of the AIDS epidemic, one of the things that happened was, unfortunately, a lot of patients passed in the early days before we got the cocktail in 96 roughly, and people were making, surviving longer. And a lot of patients at Whitman Walker who passed bequeathed their real estate to Whitman Walker. You guys can correct me on this if any of this
No,
is...
yeah, that's 100% accurate, and they still do.
Yeah.
Just less so because thank goodness less people are dying.
Yeah, and
right?
then
But
yes, I know that there's something ironic about that, but that's fine. We don't want
no.
perhaps we're going to die later, but we will still give you whatever property we have.
Exactly. We would love that.
Real estate is pretty much useless. And I think one of the I think it wasn't the Elizabeth Taylor Center, wasn't that from a former patient? I don't recall who that was, but.
Sort of, it was a combination, then government funding as well as our Max Robinson site. But yeah, people would give us their homes or all of their savings. Some folks had no family who they wanted to give it to. I shouldn't say they didn't have family, but at the time they maybe didn't want to give the family their funds, and their friends also in a lot of settings were sick and dying as well. But even just as recent as last year, someone actually donated their condo to us, and we sold it and then used the profits. What's interesting that I just, a fun fact, and I know that we are very over, so tell us to shut it, was I actually grew up next to a Whitman Walker house. So that was my first foray into working at Whitman Walker, was when I was in middle school and high school. I grew up in Arlington, so just across the river. You're again familiar with DC. Someone owned that house, died, gave it to Whitman Walker, and then it ended up being part of, like, we had for maybe 15, 20 years, a Whitman Walker kind of housing project. And there were 4 gay HIV positive men who lived in that house in the suburbs. And you gotta love Arlington at the time that people complained and saying, I don't want my kids to know about this world and this life and whatever. And I remember, it was really, I was in the 7th grade, and I remember my dad talking to the local Arlington Sun Gazette and saying, come on, this is the suburbs. Do we really care if they're gay or if they're HIV positive? We care if they're lawn mowed. Do they have pretty flowers? Are they bringing in their mail? And tried to remind community. And that was my first, that would have been early 90s. And I was like, what the hell, what's happening? And, fast forward 20 years, I ended up working here. And so Whitman Walker really touched people in ways that, we didn't even really realize. And we actually still have a HUD grant. It's a 40-year grant. We're on year 23 or something. I don't know where we've got a small housing project. So some apartments that we have another group manage for us, but that we work with. Called the Hearth Foundation. And so there's all these weird little intricacies of Whitman Walker. But yeah, to your point, Steve, we're not flush with cash. We haven't been for a very long time. And even then, at one point, we did have a good amount of money and people would donate things to us. But we had to sell 14th and S really to stay open. We needed cash, and, we are cash based, which is also challenging when you're third party reimbursement or grants. You don't submit a claim and get money from the insurance tomorrow, right? There's quite a delay. So we have to be able to pay people monthly. Sometimes grants don't pay us for almost a year, and it can take us a while. So we had to get to a grants perspective. So unfortunately, we had to sell a lot of that real estate to maintain. And now we're working on maintaining.
Yeah. And, Don's very good with that. And the health of the Whitman Walker
Absolutely.
Quite good, and I'm very impressed.
And we're hopeful that the diversification with the system will support that, even when Don leaves, because Don will be leaving Whitman Walker at the end of this year. This is the end of his, contract with the system, and we're actively hiring for a system CEO right now. And we just announced an institute lead, so we've got a lot of, comings and goings, and it'll be really interesting to see what the next 15 years look like. Sorry.
Now? Is that public now, the institute leader?
I believe it's public. I don't want to speak out of turn. I think it is, right, Dan?
Yes. Yeah. It is now public.
Terrific
I
choice.
can tell you who it is. It's Kellen Baker. I don't know if you know Kellen or have met Kellen. He,
Callan's been a friend of the program for years. One of the best, LGBTQ health data nerds I've ever known. Terrific presenter.
He went to GW.
Went to GW. He just finished his PhD up at Hopkins, and the man is fantastic. I'm jealous because I wanted to hire him to teach a course, and he said he was too busy, and he sort of quietly told me what was going on, and I said I'll shut up until it's public. But yeah, that's very excellent choice, and he's replacing Laura Durso, who's now over
That's right.
And Laura was a great friend of the program for years too, and she was equally phenomenal in her role there.
Laura was great, and then she got tapped by the Biden administration, and we couldn't.
It was a brief tenure, but
it was brief, but we understand. When you get tapped, you go. That is what we are public servants. So
she'll probably come back and help out another, and I know she'll be very helpful to all of us. In her
absolutely, she's great to have there as an advocate.
Yeah. All right. Well, we're over time by a few minutes, but this has been. Every time we do this, I learn something a little bit more about Whitman Walker, and it's great to have your guys' perspective because we haven't had a chance to really get to know each other. And Megan, I'll follow up about UVA stuff sometime because we're fellow Wahoos. So
absolutely. Oh, you too, Tyler?
Yeah, Tyler. Yeah, absolutely.
Excellent. Yeah. My younger sister went there as well. So as we all know, there are pros and cons to UVA. And I just wanted to apologize. I barely even got to go into COVID. And so we did a lot with COVID. you can imagine. I'm glad we had a good dynamic conversation. But basically, just so y'all know, we pivoted to telehealth in about over a weekend. Yeah. And so we had done 0% telehealth. About 3% of our staff were working remotely. We were very much in-person services. We closed one day. So we were open through a Thursday. We closed on Friday, basically so everybody could just cry in their offices and breathe, let's get it together. And then by Monday, we were doing telehealth for medical, behavioral, psychiatry, nursing. We did respiratory clinics, so only COVID care for a couple months to kind of get our feet on the ground, make sure we had all the proper PPE and whatnot. Because we do infectious disease, we were lucky enough that we had N95s already on site, and we already did some of those practices. We had done fit testing, so we were sort of prepared. Obviously, we didn't have enough N95s and still don't. Welcome to the world, right? And then slowly we've pivoted back. So we've gone to almost all telehealth to we're now at 70% in person for medical. And our biggest struggle was dental services. We tried to do dental, oral, telehealth. Just as much as we could support, is that an infection? Look in my mouth type of a thing. That continue, right? Exactly. Dan's shaking his head, and it's, we're not getting billed for that. We more just wanted to make sure, do we have HIV positive folks who have an abscess in their tooth that we have to quickly see? We're now at about 80% of our dental capacity. But again, and that's mostly because of space requirements, like social distancing requirements. As a health center in the District of Columbia, we still have to abide by the OSHA emergency temporary standard that was just released a couple weeks ago. And so we do still have regulations on lobby size, aerosolizing procedures, 6 feet apart, and masking. And obviously we're mandating masking, but as I'm sure you all are anticipating, I would not be surprised if a DC mask mandate comes back, given the CDC's reversal of guidance yesterday, as well as the messaging saying that we do have substantial community spread. And one, I will leave you with this, which I think is fascinating. Only about half of our patients are vaccinated. And we have full vaccine. We are able to vaccinate. We have a huge health education team that is actively calling all of our patients, that is doing pop-up events. We provide walk-in vaccine. I mean, again, I think you all know it's very easy to get a vaccine in the District of Columbia right now. It wasn't previously, right? We worked the systems were challenging, and we were all jockeying for a spot. I got vaccinated at the deli counter at a local Giant, we all did our part. But now we're only at about 50% of our patients, at least based on the data that we've got. So we ourselves have vaccinated about a third. And then we are members of CRISP, which is the Regional Health Information Exchange. So we can see what information is out there. And it looks like about half our patients are vaccinated. slightly less than, it's like a little bit over of half of the district is vaccinated. So we have a lot of work to do there.
Awesome. Well, thanks again for taking the time and getting us up to speed, and a lot of pretty exciting things happening over there on 14th Street. So look forward to hearing more. We have an early lunch today, so we're taking our break now, and we will reconvene here at 12:30, so about an hour and 10 minutes. And at that point, we will be meeting with our friends at HHS. And Brian Altman has put together a group of folks from HRSA, SAMHSA, and other offices at HHS and related bureaus to talk about what they're doing on the federal level on the executive side. So thanks again, guys. We will stop the recording now. And Megan and Dan, when I get back to DC, a cup of coffee on me.
Sounds great.
Great. And Carolyn, if I get your email address, I guess through Steve, I'm happy to send you the info that we talked about.
Yeah, I sent out the email to the group, so Carolyn, you can grab Dan and Megan's emails from there.
Perfect. Thank you.
That's for everybody. All right. Thanks so much, everyone.
Thank you. Thanks.
Y'all, thank you. Take care.
Bye now.